All right. Good afternoon, everyone, and welcome to the Johns Hopkins Alzheimer's Disease Research Center for Minority Aging Research Professional Development Seminar Series. Today, I'm very excited about the topic of our seminar is because we're going to learn about research opportunities to advance health disparities in minority aging research. We're going to learn about two data sets. And we're very excited to have the principal investigators for both of these data sets. And I'd like to go ahead and introduce both of them. But what we're going to do is we're going to have the presentations for both PIs. And then after, we're going to move into breakout groups, breakout rooms. And then that's where the questions and answers will take place for each of the data sets. So first, I'll start with introducing Dr. Judith Kasper, who is, by the way, one of my mentors, outstanding mentors of mine, and I'm so happy she agreed to be here today. She's a professor at the Department of Health Policy and Management. Her research and teaching interests include health policy and disability and long-term care, assessments of needs for care and service provision to physically and mentally disabled people, and the development and application of data sources, national surveys in particular, for health policy analysis and health services research. She's a principal investigator of the National Health and Aging Trend Study, affectionately known as NHATS, that's funded by National Institute on Aging to support research on disability trends and dynamics among older people. Welcome, Judy. The second speaker today is my partner in crime with the RCMAR, at this Johns Hopkins RCMAR Center, is Dr. George Rebok, who's a professor in the Department of Mental Health, and he's the PI of the ACLIS study and a multiple PI with me at the Johns Hopkins Alzheimer's Disease Research Center for Minority Aging Research. His research focuses on identifying early risk factors identify early risk antecedents and protective influences on later life cognitive health and functional decline, and as well the study of long-term outcomes of cognitive intervention trials with both well and minimally to severely impaired elderly. Welcome, George. And I think Judy is going to lead us off with the presentation on NHATS.
Okay, thanks. So I'm going to, I hope, share my screen here.
Yep.
And then I need to see if I can get this started from the top.
Yep.
So can everyone can see that okay? Happy to be here to give you an overview of the National Health and Aging Trend Study, which is has been developed to serve as a resource for study of late life disability trends and dynamics. I'm starting with a slide that I usually have at the end, but this shows you the important information about the NHATS website, which has all the information I'm going to talk about today and much more in greater detail. The website is the source for registering and downloading our public use files. It has multiple types of documentation that's been developed, including we've recently put up some on-demand video tutorials. We have a paper, one of our technical papers that has been developed based on questions from users about how best to analyze the data. So this is kind of, in a nutshell, probably the most important information from my talk today. Just to give you a little background, NHATS was developed and intended as a platform for scientific study of disability and late life, and hopefully leading to developing ways to maximize functioning and quality of life of older Americans. The design supports study of both disability trends and dynamics in older people. It was developed with broad input from many disciplines, people engaged in studying aging from different perspectives, and dissemination has served as a major objective as well of the entire NHATS undertaking. So some key features that flow from that vision. The design is one in which we do annual in-person data collection We started in 2011. That was the initial cohort that we are still following. We replenished in 2015. So that now represents a second cohort that started at that point, and we've been following since then. The sample, we have overrepresentation of people at older ages in our sample, and we also have overrepresentation of Black individuals. And we are going to be introducing an older sample of Hispanic individuals starting next year. The content of NHATS is really guided by a conceptual framework for late life disablement that I'll show you a little later. And as I mentioned before, timely data release of data files that are user-friendly has been an important objective of the study since the beginning. So NHATS is funded by the National Institute of Aging through a cooperative agreement. Myself at Hopkins, Vicki Friedman at the University of Michigan are the lead investigators on NHATS. Data collection is done by Westat, which is a large research firm that does that's known for doing national level data collection. And the development of NHATS happened really by bringing together, as I mentioned before, investigators from a number of different disciplines that we represented here. And so that was particularly important in the development phase in helping us generate content that would serve the research needs of a wide constituency of researchers. This shows you some of the areas of scientific contribution that NHATS has really contributed to. This could be a much longer list. This is selected, but you see on here things like family caregiving, dementia caregiving in particular, and I'll talk about both the National Study of Caregiving briefly as well, that is part of NHATS. Looking at long-term trends in active life expectancy, looking at frailty, prevalence, and progression, how various impairments and symptoms and figure into the disablement process, race and ethnic disparities in late life disablement. So these are all areas of contribution from researchers working with NHATS data. So let me go into a little more detail about the sample design and data collection.
Judy, before you do, several people in the chat are saying they hear background noise. I don't know if.
Yeah, you know, that's probably from my Surface. Is
okay.
that any better? I'm not.
It seems
sure.
that seems better now. Yeah, that seems better now.
Unfortunately, I'm not sure I can stop that altogether.
Okay.
But does that seem a little better?
That's much better. How does that work for everyone else? Better?
Okay.
Yeah, people are nodding. Yeah, thank you.
Okay.
Sorry to interrupt.
No problem. So the study population for NHATS is Medicare beneficiaries ages 65 and older. We draw the sample from the CMS Medicare enrollment file. As I mentioned before, the design is one that's age stratified in 5-year age groups. So we have relatively even representation in the sample across age groups from 65 to over 90. And as I mentioned before, we do oversample Black individuals, and we're going to be adding a Hispanic oversample. And we do annual in-person data collection. We started in 2011. We're now in our 10th year of data collection. This is just a table of response rates. In round one, we achieved a 71% response rate, and then response rates conditional on individuals completing prior rounds. As you can see, it's been quite high over time. We do a last month of life interview as well. I'll talk briefly about that. And so we've been able to maintain high response rates over the years in the study. our core data collection instruments, we have a sample person interview, and in a very high percentage of cases, we're interviewing the NHATS respondent. We also do use proxy respondents for a small percentage of people who are unable to participate for themselves, usually because of severe impairments, including things like dementia. We do a set of physical performance activities. I'll show those later that are recorded in an activities booklet. That's all sort of part of that sample person interview. For people who are in residential care facilities that offer services, so that includes not only nursing homes, but also assisted living or CCRC kind of environments. We do a brief interview with a facility staff person, so we can get information about the place that people are in. And as I mentioned before, we do a last month of life interview. We started that in the second round for participants who have died. That's conducted with a proxy respondent who's typically a family member and focuses on that last month of life experience, both disablement aspects of the last month, but also the medical care experience of people. This is the NHATS conceptual framework. We view disability as an umbrella concept, and these are all components of the disablement process. Much of the early work focused really only on this set of areas, people's health conditions and impairments and their capacity. But we have explicitly incorporated elements of the environment that people are in as an important component of understanding disability, and the accommodations that people make. These could be use of devices, it could be help from others, it could be making changes in the environment or how they do activities. And then outcomes of interest are activities important to people for independent living, but also participation in activities that are productive and that people value in their lives. So this is a slide we show a lot, which is not meant to be necessarily read. It shows all the different sections of the NHATS interview. And the point of the highlighting in white is that these are all sections that touch on that conceptual framework that I just talked about. So, very large part of what we collect information on in NHATS, stems pretty directly from that conceptual framework. I thought I would talk in a little more detail about the key activity measures and the physical and cognitive capacity measures. So in the self-care and mobility realm, these are the activities that we ask about. And for each activity, we collect information about whether it's done with a device or not. We ask about difficulty. We ask whether people are doing it less often than they did in the prior year, and we ask about help with activities. For household activities and medical activities, we ask about whether people do the activity by themselves, whether someone does it with them, whether someone else does it for them. We then also obtain information about whether things are done less often, or and if they do the activity by themselves ever, is it difficult? We also have introduced a number of questions about doing some of these activities online, things like shopping and taking care of bills and banking and so on are things that people increasingly do online. And another important dimension here that's not on this slide is that we distinguish between if someone else is helping or involved in the activity, we distinguish whether this is going on for health and functioning reasons or whether it's preference. I mean, if you think about meal preparation, sometimes someone may be doing this for the person because that's the agreement they have, that's the person who likes to cook and do meal preparation. It's not really a health related issue. And so that is an important distinction that is made. And then finally, the participation activities that I mentioned, there's a series of those. And we ask about whether people value the activity, and we get information about health or transportation issues that may limit their ability to do the activity. We also have a verbatim open-ended favorite activity that's coded, which we track over time. And that could be a whole range of things. It could be, playing bridge. It could be playing the piano. It could be, reading, going to the library and reading books. So let me touch briefly then on the physical and cognitive capacity measures. So physical capacity includes both self-reported measures, like the ones you see here. Many of you will recognize these are quite similar and drawn from like the NHATS, some of the NHATS items. We also do a set of performance-based measures. As I said, we conduct balance stands, chair stands. We do a timed walking course, grip strength. So these are a set of activities that take about 20 minutes out of the interview time and are part of the data set. So in terms of the cognitive measures, we have a variety of information that we collect, reports of diagnosis. We use the AD8 when we're doing a proxy interview. This is a proxy screening instrument for Alzheimer's disease. And then we have our cognitive assessment battery, which touches on 3 areas: memory, orientation, and then executive functioning. So in the memory area, we do have some self-report items about memory problems. And then we use the 10-word immediate delayed recall. You see the orientation indicators here. Those are, fairly standard. And then we do a clock drawing test. So from this information, we provide users with a dementia classification. There's a technical paper on the website that describes the development background for this classification. And it draws on, reports of diagnosis and the AD8 score, and scores on the cognitive assessment items. We did, the technical paper also reports on a sensitivity and specificity analysis we did of our classification against the HRS Adams data, which is a diagnosed sample of individuals who've gone through a complete clinical workup. So we provide this technical paper with the programming statements for users to use, but people also, of course, do use the individual items. We're adding a new cognitive measure this year. It's drawing on a battery from a firm called Cogstate, and it relies on a series of activities looking at playing cards. And will give us some additional information on psychomotor function, attention, and working memory. I wanted to touch briefly on the fact that we have other kinds of data and data files that have been brought into NHATS over time. I've already talked a little bit about the last month of life interview that is done every year. We did a dried blood spot data collection in round 7, and there is a data file available that has assays that have been performed from those. And we are currently completing work on files that have genetic information. We did DNA isolation from the dried blood spots, and there's been a genetic array done, if I'm describing that correctly. And it'll be deposited in a data depository that the NIA has established. And there'll be, ways of accessing that information. We're adding an accelerometry sub-study as well this year, which will then be ongoing. This is wearing an actigraph watch for a 1-week period. And we'll, of course, collect all the information around people's movements over that time frame. We did a COVID data collection. So I just wanted to mention that briefly. Again, that's available on our website. We did it was a mail-back survey, which we did with both our NHATS participant and then with family members and friends, and really focused on how some of these activities were done pre-COVID and how they have changed, how they changed as a result of COVID. So again, that's on the website. We do periodic modules that are added in, and these come from external investigators. We put out calls for modules. We won't be doing that this year because of going into replenishment next year, but usually this is an annual call, and we've had a number of Hopkins investigators. The sleep quality module came from Adam Spira, for example. The healthcare preferences and engagement was Jennifer Wolf, Cynthia Boyd. So it's a nice way of adding, new content to the core and giving external investigators some opportunities to collect information that enhances the whole NHATS offerings. We also have a 1940 census linkage that has been done and will soon be available. So let me just quickly, how much time do I have left? I think I'm running toward the end. So the National Study of Caregiving has been done periodically. It was done in 2011. It was done again in 2015 and then in 2017. It is going to be done annually starting next year. And this interviews persons who are named as helpers in the NHATS interview. And we try to interview all caregivers up to 5 that are named. And the focus is really on the caregiver's situation and experience. So, and we do it closely tied in time to NHATS so that when we're asking about things like the effect of caregiving on the caregiver's ability to participate in activities and so on, we kind of have that link to knowing what level of caregiving they're involved with. So these are some of the kinds of topic areas that are covered in NSOC, and positive and negative aspects of caregiving, intensity and duration of care, and a number of other areas. And so the ability to link the NHATS person with these caregivers has been has proven, very useful and has produced quite a lot in terms of work on family caregiving. Just quickly to review the kinds of files. So our public files are, you register on the data set, you are on the website, you download them. Most of the information we collect is in the public files. We have a set of sensitive files that provide more detail. For example, age in years is in the sensitive file. On the public file, we have age and 5-year categories. Obtaining the sensitive files is not onerous. It's a small 1-page form, so we can confirm your research credentials. The restricted files, there are two kind of buckets of those. One has to do with linkage to Medicare, to CMS data. There's a process in place for that. There's a document on the website that explains the application procedures and the steps. We have Medicare data linkages, we have Medicaid data linkages, and the document lays out, what is available. The other bucket of restricted files is in a data repository that we have now established at the University of Michigan. It's a virtual enclave. It has all of our geocoded information. The census files will be there as well. And so you can apply and access those files virtually. We have some investigators at Hopkins who are doing that. Again, there's a document on the website that lays out, the procedures for access there. So I'm going to stop again by putting the website up. And thank you. And I'm looking forward to answering questions in the breakout.
All right. Well, thank you so much, Judy. That was terrific. And as Roland mentioned at the beginning, we will hold questions until we do the breakout sessions. So I'm going to share my screen here. Can everyone see that?
Yes.
All right. Okay, so I'm going to be talking about the active study, and I'm really delighted that one of the active PIs, Dr. Sherry Willis from University of Washington, is with us here on the call today. And she and I are MPIs of the active 20-year follow-up study. And I'm also glad that several other folks who have been involved in the active study over the years are also able to join us here today. So I thought we'd start out with just looking at the active study timeline. We're actually in our 25th year of the active study, believe it or not. The study initiated in 1996 with an RFA that was put out by the National Institute on Aging and the National Institute of Nursing Research. And there was a multi-site trial funded across 6 sites. And we did a initial pilot trial and then a 4-armed randomized control trial with 2-year follow-ups. And then we did 5- and 10-year follow-ups and published papers on those follow-ups. And then the last 5 years, we were funded to do a 20-year follow-up data linkage study. We're not actually out in the field doing face-to-face interviewing or evaluations, but we are linking active data that we've collected through year 10 to large data sources like Medicare claims records and National Death Index records. We also had an administrative supplement on race and social determinants of health that was funded by the NIA. And we are working on a special issue on race and social determinants of health for Journal of Aging and Health. That special issue is being co-edited by Dr. Roland Thorpe and Dr. Olivia Clay from University of Alabama, Birmingham, and Sherry Willis and myself. That will hopefully be coming out sometime later this year or early next year. And again, the focus is on race and social determinants of health. And then we're also gearing up for a data archiving effort to archive data that were not archived from the first phase of active, as well as data that we're collecting in this second longer term follow-up phase. And I'm pleased to say that Dr. Alden Gross will be leading that effort. And I think he he joined our call today as well. So I'm glad he could be here with us. The active data is in a public use data file through NACDA, the National Archives of Computerized Data on Aging. So from the baseline to the year 10 follow-ups, the data are available. And we are working with NACDA now. They're through ISCPR out at University of Michigan. We're working with them to archive the longer term follow-up data. So what I wanted to do in the time we have is to just give you a quick overview of the active study, present the design of the trial, and talk about some of the major, very selectively, some of the major outcomes of active so far, and then focus specifically on opportunities for minority aging research on health disparities and Alzheimer's type dementia from baseline up through 2021. So the design of the active trial was largely pre-specified by this RFA that came out in the mid-1990s. And there were three major emphases that were in this request for applications. One was for a common multi-site intervention protocol. So these protocols were shared across the intervention sites. There was a focus on everyday independence and cognitive components of functional competence. That was our primary outcome in active. And that really made it very different than any of the other cognitive intervention trials that had been done up to that point. And it still makes active fairly unique in that we are really focused on function and functional independence as our primary outcome. But the interventions are at the level of basic cognitive abilities rather than trying to directly target those primary outcomes. So the thought here was that if we could move the basic cognitive abilities that really support your everyday activities like managing your medications or your finances or preparing meals, that this would improve then these everyday functional competencies. So here's the active steering committee. Again, there were 6 sites, Hopkins being one of those sites. New England Research Institutes was the coordinating center. And then this was a cooperative agreement with the National Institute on Aging and the National Institute of Nursing Research. So here are baseline characteristics. We had over 2,800 people in the sample, making it by far the largest cognitive intervention studies to our knowledge that has ever been done with an older sample. The mean age was around 73.6, so with a range from 65 to 94, 3/4 female, 26% African American. And that really makes active, again, fairly unique in that there are very few large cognitive training studies that have had a proportional representation of African Americans and other races in the sample. We had fewer than 1% of other races and biracial and multiracial individuals in the sample. It was predominantly African American. And here are the other characteristics. People at baseline, participants at baseline tested normal cognitively on the MMSE. Here's the design of the study. And again, the question was, does intervening on these basic cognitive abilities transfer to real world tasks? And we had kind of a multi-step screening and assessment process at baseline with over 7 hours of assessment spaced out over 3 days. Randomization into 1 of 4 arms, 3 intervention conditions and a no contact control, and then immediate follow-up and then periodic follow-up through 10 years. And we also randomized half of the initially trained people into booster training at 1 year and 3 years post initial training. And then we had this 20-year follow-up linkage study. And the study outcomes, our proximal outcomes included the cognitive ability domains of reasoning, memory, and speed. And we had multiple ability markers of each of these domains, multiple tests. And then for the primary outcomes, it was everyday problem solving, speed, driving, and ADL, ADL performance. And again, we had multiple markers of these outcomes. And then secondary outcomes like service use, health status, and life space. Here is the active conceptual model. You see the randomization into one of the 3 training conditions. And then these arrows represent direct effects or specific effects of the training on their ability outcomes. We didn't expect, we thought that the training would be very target specific, so that if you're trained in memory, that's what would improve, not reasoning or attentional and processing speed. But then there was expected to be generalization to these primary outcomes, as you can see here, based on previous findings, and then downstream outcomes or more distal outcomes like health-related quality of life and mobility. Part of the active design included interventions that had shared common structural features. These were all small group interventions, a trained facilitator, fairly modest dose of intervention over a 6-week period, 10 sessions. And to complete the training, he had to attend at least 8 out of the 10 sessions. And I wanted to give you just a couple examples of a few examples of the training programs. Here is an example of the memory training program. This is a categorization exercise based on some of the memory principles we teach, and having people come up with a category label and then using that label as a cue for recalling items within that category. So here you see the 3 categories are metals, sports, and fruit, and then you see specific items that are members of each of those 3 categories. So that was an organizational categorization exercise for memory. Here's reasoning training. This was one of our real life training exercises where this is a hypothetical patient who's taking multiple pills at different times of the day and night. And so you had to recognize patterns of the medication taking and kind of fill out a medication schedule here. And we know that many older adults are on multiple medications, so this is a real world challenge, and the reasoning training was in part designed to deal with this medication management problem that many older adults experience. And then speed of processing was a computerized intervention, was still done in small groups. It involves something called the UFOV, the useful field of view task. Here is a subtest 2 involving dividing attention, where you had to pay attention to the central fixation point, where it was either one of these 2, a truck or a car here, and you had to decide which it was. And then at the same time, you had distractor stimuli on the periphery of the screen, and you had to identify in which of the outside spokes was the object located. So it was a divided attention task. So just very briefly, the training outcomes, we had the 10-year results published in JAGS, and we had significant findings for both reasoning and speed, that through 10 years, there were still significant effects. Memory trended in that direction, but it wasn't quite significant. But the fact that these training effects held up 10 years post-intervention with only 6 weeks of training was really kind of remarkable. I don't think it was anything that we expected when we started the active study. And it was a protective effect. You noticed overall the trends are downward in terms of the cognitive trajectories, but the people that were in the training groups showed less decline over time than people that were in the control condition. And the primary outcomes, one of the main outcomes was IADL functioning, and this is self-reported IADL difficulty. And here, all 3 of the trained conditions resulted in participants reporting less difficulty performing everyday tasks like managing medications or managing finances compared to the control group, here shown in the red line. And that held up after 10 years post-intervention. And that was really one of the first times anywhere in the literature that you had this kind of transfer effect reported for everyday abilities like IADL function. And we also looked at secondary outcomes like mobility and driving, internal locus control, quality of life, depression, SF-36. One of the main outcomes here was with auto crashes. We found that both speed and reasoning training reduced high risk for crash, and it actually reduced the risk to baseline levels of the low risk participants. And so this is, again, evidence of the transfer of training beyond just what was trained to a real world task. And then, of course, the question that everyone always asks us is, does this kind of training prevent dementia? And of course, ACTIVE was not set up as a dementia prevention trial, but nevertheless, we can look at long-term effects on dementia. We did not have clinical diagnoses of dementia in ACTIVE and adjudicated cases, but we did come up with our own empirical definitions shown here based on various cut points or based on MMSE scores or self or proxy report of diagnosis of dementia. We did some sensitivity analyses. All of these in different combinations seem to work fairly equally well in terms of our outcomes. We did not find, and this is only through 5 years, that the training led to reduction in incidence of dementia. Here you see dementia-free survival probability curves. You see some separation between the control group and the training group, but overall not significant, although it seemed to be starting to trend in that direction. Jerry Edwards, who is one of the members of our ACTIVE team, published a 10-year follow-up study where she found that the speed of processing training did make a difference in terms of lowering dementia risk, and there was a dose dependency with that. So I wanted to just focus for a few minutes on the opportunities for minority aging research on health disparities in Alzheimer's dementia. We are very much focused on assessing race and social determinants of health in relationship to our outcome variables. As I said, the baseline sample, a very large sample, 2,800. Part of our administrative supplement that we receive from NIA is to look at racial differences, associations of the social determinants with outcomes amongst control participants over time. And we had almost 700 controls, 26% of whom are Black. And then look also at intervention effects. Are they similar for Blacks versus whites and across different social determinants of health? There are differences in terms of racial distribution by site in ACTIVE. We had the 6 different sites, as I mentioned. 26% of the total sample is Black, but the sites range in terms of percentages from anywhere about 4.5% to over 40%. So we had some sites like Wayne State University in Detroit. It had a very high percentage of African-American participants, and other sites like Penn State, where the percentage was much lower. But there was a range across all the sites. At the 10-year assessment, where we're still doing in-person assessments, we had data collected for over 50% of the original sample of Black participants. The N for that original sample was 728. At year 10, we were able to reassess 383. This is the breakdown across the different intervention conditions. And then we are looking at specific social determinants of health categories. This is based on the Healthy People 2020 report. Here are the 5 categories, and we've tried to operationalize these major domains in the ACTIVE study, drawing on different data sources and different measures that we have available, not only through ACTIVE, but also through things like TransUnion credit records, 2000 census data, the NAICS data, which is the North American Industry Classification System that classifies businesses in different neighborhoods like grocery stores and fitness centers, other businesses. So this is Olivia Clay has been leading an effort to take these sources and provide composites for the social determinants of health. And he's written a very important users guide for using the social determinants of health data within the active data. And it's really been a great help in terms of folks who are using these data. Here's the neighborhood and built environment data that's relying on the NAICS and the 2002 economic census data. So in our current funding cycle, as I said, we've been funded in 2017, we were funded for a 20-year follow-up after baseline. We are accessing Medicare and Medicaid claims records. We have credit bureau data that we've accessed, crash records from state-reported DMV records, and mortality data through the NDI records. And so as I mentioned at the beginning, these plans to archive the active data. We want to archive the phase 1 data that had not been archived in 2010. We have some data, for example, that from final disposition forms that we administered that haven't been archived. We have some data from the actual training sessions that were never archived. So we want to make a more complete phase 1 data set, and then archive the phase 2 data that we've collected since 2010, and these data sets include the ones you see listed here. We have NDI records through 2017. We have a second request in to get those records now through 2019. We have recorded crash data through 2017, these social determinant composites, occupational complexity scores through the Dictionary of Occupational Titles. And we had Medicare data that required in phase 2. This is being led by the University of Pennsylvania group, Norma Coe and her colleagues. And we have data currently, I believe it's through 2016. We're going to be requesting updates from Medicare, and we are planning to archive in those data in collaboration with MEDRIC and Acumen. So University of Pennsylvania is leading that effort. So I think that brings me to the end of the presentation. So with that, I will stop my share. And we've got, less than 10 minutes here, but I think maybe if we just go to the breakout rooms for maybe 5-6 minutes, you have specific questions for either Judy or I. The first breakout room will be the NHATS breakout room, and the second room will be the active breakout room. So what I'm going to do is